Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mamines, breast surgical oncologist. I work at Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
35-year-old woman with pathologic prognostic stage 3A, right invasive ductal carcinoma with focal mucinous features, grade 2, ERPR positive, HER2 negative, who completed neoadjuvant dose-dense chemotherapy with doxorubicin, cyclophosphamide, and paclitaxel, and is now status post right modified radical mastectomy. And we're going to really talk about her adjuvant therapy. Is there any benefit for additional chemotherapy after the planned adjuvant radiotherapy? So that's going to be the focus of the question that has been posed. So the patient initially presented with a palpable right breast mass in a flattened right nipple. Excellent performance status. Her medical history includes seizure disorder and schizophrenia. She is premenopausal G0 and history of breast cancer in a maternal cousin. Her oncology history, as you see here, in August of 2020, she underwent bilateral diagnostic mammogram, which was negative in the left breast, but the right breast revealed an irregular mass in the subareolar region, causing the nipple retraction. She subsequently underwent a right breast ultrasound, which confirmed the mass and measured 4 to 5 centimeters with a questionable right axillary lymph node. She underwent a ultrasound-guided core biopsy as well as a right axillary nodal biopsy, which demonstrated invasive ductal carcinoma grade 2, ERPR positive, HER2 negative, with confirmed pathologic metastasis to the right axillary lymph node. She had a CT chest, abdomen, and pelvis for systemic staging. This doesn't mention it, but also a bone scan that showed no distant metastasis. She did have genetic testing, which was negative, and she underwent a breast MRI, which demonstrated, notably in the right breast, the biopsy-proven carcinoma, measuring 1.2 by 2.6 by 2 centimeters with associated dimple retraction, skin thickening, and contiguous non-mass enhancement spanning up to 6.7 centimeters, as well as the enlarged biopsy-proven metastatic right axillary lymph node, measuring 2.6 by 1.5 by 1.4 centimeters. Between October of 2020 and January of 2021, she received neoadjuvant chemotherapy with dose-dense doxorubicin, cyclophosphamide, and paclitaxel. And then in February of 2021, she underwent a right modified radical mastectomy. The pathology demonstrated a 3-centimeter invasive ductal carcinoma with focal mucinous features grade 2, still ERPR positive, HER2 negative, and unfortunately, she was found to have 13 out of 21 lymph nodes positive for metastatic disease. If we can have Dr. Chalkelson kind of highlight for us some of the MRI findings.
Sure. So on the image of the left breast, I see nothing. And you can see that she has enhancement, an enhancing mass in the just slightly medial portion of the right breast anteriorly. And then there's another large area of enhancing mass that's actually extending directly to the nipple and also extending along the medial portion of the right breast. So it looks like she has tumor involvement of the skin there as well. And I don't have an image that includes the lymph node, but it's biopsy proven positive. So.
Thank you so much. And so the pathology demonstrated a residual cellularity of 30%. So presumably there was some response to the neoadjuvant chemotherapy. but still stage YPT2 in 3A, and her residual cancer burden index was 3. So wanted to talk about is there a role for additional chemotherapy after the planned adjuvant radiotherapy? Dr. O'Shaughnessy, do you want to start us off with that?
There's no level 1 evidence that would lead us to administering additional chemotherapy. I do think about the CREATE-X trial with the 6 months of adjuvant capecitabine. ER-positive patients were included. It was a small number, and the point estimate was not significant. It was 0.88, suggesting possibly that there's a subset of patients that might benefit. We did an adjuvant trial of capecitabine. It was AC followed by docetaxel versus AC followed by docetaxel plus capecitabine. And the trial, unfortunately, was underpowered. The hazard was like 0.82, but it wasn't statistically significantly positive. We did central Ki-67 and looked at ER-positive breast cancer and benefit from capecitabine. Capecitabine's obviously an S-phase agent. And what we showed in a hypothesis-generating step analysis, looking at disease-free survival, 5-year disease-free survival by Ki-67, is that when the upfront, these patients were all adjuvant. So this was an upfront biopsy. When the Ki-67 was greater than 20%, the curve started pulling apart and kept pulling apart, as the Ki-67 got higher. So sometimes in a very serious situation like this, I will utilize capecitabine kind of based on the CREATE-X. I mean, the whole trial was positive. I know it's not indicated like on NCCN, et cetera, but the whole trial was positive, and there was a trend in the ER-positive patients. One thing that I worry about when I have a patient like this who's very young and is very high risk, and particularly when the biology is like this, it's grade 2, it's really ER-driven, ER-PR strongly positive. I worry about delaying the very best therapy of all, which is the endocrine therapy, while she gets 6 months of chemotherapy. And, of course, we can start it right after chemotherapy if she goes to surgery. So she's not really being, but, in the TEXT trial, they utilized the LHRH agonist triptorelin from day 1 of chemotherapy. And then patients after their chemotherapy, if they got chemotherapy, they were randomized to the exemestane versus the tamoxifen. So that was very interesting because we don't have any prospective randomized data, looking at plus minus LHRH in this young group. Now I'm talking under 40 now, and so because this is the group that doesn't necessarily get full ovarian suppression with chemotherapy. And all we can do is do cross-trial comparison between SOFT and TEXT, because in SOFT, they got their chemotherapy first. Their ovaries had to wake back up again and become premenopausal. Then they were randomized to tamoxifen, triptorelin, tamoxifen, or triptorelin exemestane. So you're kind of looking at bringing in the LHRH agonist after chemo versus bringing it in with chemo with the TEXT is a cross-trial comparison. That when you look at the prognostic features and the actual patients, they're very similar between SOFT and TEXT, and TEXT did no worse than SOFT. In fact, they did a little better. There's about 5% improvement in disease-free survival, but it's a cross-trial comparison, but they didn't do worse. So I will tell you that my practice pattern with this more indolent biology is to generally start the LHRH agonist along with chemotherapy. If I really am concerned, I've got a very high risk cancer and it's really more ER dependent.
Perfect. That's so helpful. If you just might comment on if this patient, for example, did have a triple negative phenotype rather than hormone positive, what would be your approach in terms of considering additional adjuvant systemic chemotherapy?
So she's had preoperative AC paclitaxel, and she's not had preoperative carboplatin. And in a high risk situation, I would have added the carboplatin to her, although we're waiting on data from, B59 and the brightness trial is going to actually report out some systemic, mature systemic data as well. We're waiting on those results to see if carboplatin not only increases PAF-CR, but also improves invasive disease-free survival. Nonetheless, I give it the benefit of the doubt in a high-risk woman. So But if she had just had ACT, I certainly would offer her 6 months of capecitabine, as per the CREATE-X trial. In this situation, I have given carboplatin, 4 cycles of carboplatin, AUC of 5 or 6, right along with the capecitabine. They don't lose their hair, very well tolerated. And so she's in a really tough situation here with this kind of high risk disease. And I would probably give her carboplatin along with capecitabine in the adjuvant setting if she didn't have the carbo pre-op.
Perfect. And if we just might go back to our hormone positive patient, given that you've kind of outlined for us the data about additional adjuvant cytotoxic chemotherapy, what would be your thoughts about other adjuvant strategies, such as an adjuvant CDK4/6 inhibitor?
So certainly I would offer her, of course, optimal endocrine therapy. I will tell you, I worry about our ability to fully suppress the ovaries in one so young with LHRH agonists, and particularly since, at least in our world, for leuprolide, for example, the only availability on leuprolide is the every 4 weekly. We can't get the every 12 weekly or the every 10 weekly. Sometimes I give it a little shorter and people so young. And sometimes insurance companies won't cover a 12-week depot of Goserelin, and they'll only do 4 weeks. And that really puts a burden on patients, to come in. So I would really talk to her about a BSO, given this very high risk situation that she's in, as well as an aromatase inhibitor and zoledronic acid. What about abemaciclib? What about adjuvant abemaciclib in this very, very high risk situation? So my opinion is to wait until we have more follow-up data, because I just want to see not only that the curves don't come back together, I want to be sure there's no change in biology. When you inhibit CDK4/6, I just want to be sure that we're not doing something untoward. And so my opinion is to wait until we have more follow-up data, and when people are further into their CDK4/6, and particularly when they stop the 2 years of the CDK4/6 inhibitor.